Hi everybody, and welcome to the EGP Learning Podcast. In this episode, I'm going to talk to you about how I'm going to look at improving the PCN Specification DES. So I reviewed this document last week and talked about all the pluses and minuses, I guess, in some way, because I wanted to more than anything explain the document to people, because I know that in my local area this has proved really effective. Today I'm going to focus on what I would do to change it, because I'm being slightly opinionated and think I have the opportunity to do so. So thank you for joining me, first of all. I would try and answer any comments that I see in the comment section. I've just realised it's quite small on my screen, so apologies if I miss things, and definite shout out to some of the people watching at the moment. So I know I've already got people like Craig Nikolic and Fazana Hussain already on there and saying hi to everyone. But I'm going to try and cover this as best as I can. If you're watching this after the event, so you'll see some comments on the side that were made during the live cast, and underneath you'll see further opportunities to comment in terms of what you think of this particular live stream. If you are watching, definitely subscribe. I'd love it that you get all my content. And if you're listening on the podcast forums, so this will be out a little bit later, a day or so later, for you to listen to. I hope you found this really useful and effective, and leave me a review. Would love that, especially on iTunes. Anyway, getting straight to the content and stuff. So if you do want to check out my earlier review, the links to that and various other things I'm going to talk about are in the show notes below. So do check those out. Quick declaration. So I am a GP and I'm not involved in any of the negotiations apart from feeding back into them like many people have already done. I believe it's something like 1,600 replies already. I am, however, Clinical Director of Nottingham City East, so that's our network in the Nottingham City area. It covers 66,000 patients, about 7 practices and stuff. And if you want some backstory, I've written something like this before, actually. Back in 2015, when Jeremy Hunt, just before he released the 5-year forward view, I did a blueprint of further care for primary care. I did that with a colleague of mine, and that went down quite interestingly, and you're welcome to check that out as well. So, in this, I'm going to talk firstly about kind of some of the general changes and headline changes I would suggest making, and then we'll go through each of the specification in turn. I will point out these are my own personal views. This is not of the network or anything that I represent, although I have incorporated some views from the variety of forums that I'm on, so things like Facebook groups and Twitter chats and that kind of stuff, so I've incorporated a lot of those into them. The first thing I'd like to talk about is something I like to call Ethos. So obviously this specification was released at a challenging time for many people. A couple of days before Christmas, over the Christmas period, not really had the opportunity for many networks to physically meet and discuss these individually, and that may impact the feedback. I know in my own network we've not had the actual opportunity to meet face to face, and trying to insist that people do this before the deadline for the spec on the 15th was not something I was going to put even more so on my network colleagues and stuff, but we tried to negotiate that over technical methods and that kind of stuff. But I know that the way that the engagement has happened as well from NHS England has both been a positive and at times a negative. So definite shout out to Nikki Kanani. She's worked tirelessly in terms of trying to get as many people to feedback on this topic as possible, and you can see that in various different of the WhatsApp group chats and Twitter and that kind of stuff, and the Twitch chats that she's been doing. However, there has been slightly negatives as well, so I'm aware that one of the first webinars unfortunately didn't go so well. It kind of was effectively like they were just reading the spec out to lots of people, not listening to the feedback, and this has led to somebody resigning on the webinar and stuff. So not a great way to try and instill confidence in the feedback mechanism. I'd also like to point out that at various points throughout the document does make reference to evidence, and particularly looking at a lot of the Vanguard trials to use as evidence for a lot of the outcomes and the metrics and that kind of stuff. Although one thing I would like to point out, a lot of the Vanguards were significantly funded better than what the current funding is being offered in terms of the individual aims. And I guess the way I liken this is it's like you're saying to people, here's a recipe, I want you to cook a meal for 4 people, I'm going to give you £10 to do it. That's the Vanguard. Yeah. But then with this, we're being asked to do exactly the same thing, but only given £2 to do it, and you're not going to get the same meal. So I think it's important to recognise that. The key point is that the DES was designed to try and stabilise primary care. That was the message that we were all given when we signed up as clinical directors, and they have had the opportunity to get so many enthusiastic people join to become clinical directors, to lead the networks, to try and improve care. And actually, the tone of this document has not been received very well. It's clear that it's caused challenges to many people, and as a result of that, some people have even been sceptical to say that the document has been released so intentionally far to the right, so intentionally challenging to meet, that then when the negotiations happen, that a bit of a softening and stuff will be accepted because it's so much better than what we've currently been offered. And that may not still be the best offer for primary care. I mean, that's a kind of skeptic's dream, isn't it? Really, those kind of theories and that kind of stuff. But I would say simply, we need to see a definite improvement in what's been happening. Anyway, let's move on. As I said, this is a combination of views of people I've been around and stuff. So one of the things I would like to focus on, that if you're going to improve the specifications, is look at trust. Okay, so I would keep the current structures that we've got. If you look at a lot of the forums and the discussions that have been happening, there have been lots of calls for what should happen with the PCN specification DES, and a lot of people are actually calling for them to be basically just removed, just scrapped and stuff. But I would keep the existing structures. I do think networks have an opportunity to build on relationships between practices and local areas, and actually therefore deliver better care than individual practices may be able to do across the country. There's no doubt that some practices are doing amazing work, but actually working collaboratively with your neighbours and working collaboratively with the other groups around you, I think can have a much better impact in terms of the care we're trying to offer. As long as there is the support and funding to do so, that's the important part. It's important to remember that general practice offers 90% of the NHS care for less than 9% of the funding. I mean, where else do you get that kind of efficiency? And actually trusting general practice to just simply continue to do that, that would be amazing if it happened. So one option in terms of changing and improving the DES is just simply give the money to general practice and let it do what it has done time and time again and offer decent care. The reason why we've had more challenges in general practice is because of years and years of significant disinvestment in general practice, and that has led to the situations of having to wait for so long for appointments, of having reduction in workforce. All these things are driven by the lack of investment that we have seen in primary care. So actually, if you invest properly in primary care, you will see a return on investment significant fold over. I appreciate that there will be some people in higher up places that feel very, very anxious about that concept and giving money to general practice to effectively do the job that it can do really, really well. Because for whatever reason, it may be things like the Daily Fail having their headlines of 4.5 billion given to GPs and that kind of stuff. The reality is we're not going to pocket the money. That's not how we work. We work to offer decent care to our patients and stuff. But if that's a concern, then just give it to the networks. The networks are the collaboration of practices. Give it to them to administer and manage and fund effectively clear, locally driven outcomes that can benefit their population. And give us the trust that we will do that. That we're not just going to take the money and run, because that's not what general practice does. Anyway, I'm not going to keep pounding on that part, but that would be the perfect fix in my eyes. I appreciate, though, we don't live in a world where GPs are trusted in that way, despite the fact we are the most trusted profession in the country. But hey, if we are looking at the workload implications, though, I think we do need to take a quick note in terms of some of the documents that have come out over the past week in particular, and that's one of the reasons why I've delayed this slightly. The first and foremost is the Buckinghamshire, Berkshire and Oxfordshire, apologies if I got that the wrong way around, LMC have released their document, which I think is one of the more notable one, that obviously calls for various things, particularly in terms of the amount of workload that the new DES will have for a typical PCN and a typical practice within that nature, but also then talks about effectively handing back the contract here and now. In that point, I don't agree with the BBO in terms of, I think they clearly have done a lot of work on the document looking at costing out the services, and actually I agree with much of their costings. I do think there may be some duplication of the DES that it hasn't been accounted for, and that may be because it's not completely clear in the DES itself as to how that can work. Things like the MDTs, logic would say that you should be able to have the same MDT for various different strands, but again, the document isn't very clear on that point. But I think that the types of patients you will see, there is actually a lot of harmonisation throughout the specification in terms of which patients to categorise in. However, one of the things that's clearly evident that there is an increase in workload, and one that is not covered by the funding that's being offered. As I said, my personal view would be that we actually wait to see what the specification becomes before people recommend handing back the DES contract. Because again, this is the draft specification. It's the first time we've had a consultation like this, the opportunity to feedback before it becomes the specification. So let's see and trust what can happen with that. Really tight timeframes, no one's doubting that. But as a result of that, I would really recommend people just wait and see what happens, and then trust that the NHS England /I and the GPC can work this out. Another document I will just mention though briefly, and I do have another declaration here, so I am the treasurer of GPSurvival. GPSurvival have written an excellent letter that I would recommend people have a look at, and the link is in the show notes and stuff if you want to do so, in terms of their view of the new specifications and calling on decent funding and for this to be looked at much more effectively. Do fill out if you want. I can see Nicholas Grundy, our chair, also on the Twitter chat, so yeah, definitely shout out to everybody there, and I hope you have a look at that. Anyway, the headline improvements. So I split this category into two different sections. So number one is looking at time, because actually time is the most valuable thing in our universe. Personal view. But the first one is simply, if you were going to make a change, delay the specifications. The timeframes, as I mentioned earlier, are very tight. We're talking about the negotiations, from what I've been hearing, would have to be all done by the end of this month in order for everything to be out and ready for April. I mean, that is an astronomical achievement if they managed to do that. But to go through, 1,600 different responses, probably more by the time it finishes, to analyze that data, to then function that into a negotiation, giving yourself 2-3 weeks to do so, really tight. And actually, don't forget the PCN DES, although it was launched last April, it wasn't actually started in July 1st in 2019. So why not start all the metrics from July 2019? I completely appreciate that a lot of the funding mechanisms must work from the tax year in terms of April and all that kind of stuff. But actually, why not start the funding? But in terms of the actual metrics and specifications, delay them. So it's a proper year. Give us the full year to try and get our heads around in terms of relationships with other people, in terms of how we're working together. Give us the time to do so. Because actually, as we've seen time and time again, you give general practice time and resources, it will always perform. Next one, clarify the specifications themselves before releasing them. So unfortunately, during the DES document, there's various different specifications that basically have the words "to be confirmed" written all over them. Please don't do that. It's so disheartening. It is so frustrating when that happens with these kind of documents, because inevitably you do lots of work and find out that the way that they're being monitored, or the terminology, therefore the type of monitoring that's going to be there, just shifts it slightly, so it ends up duplicating or doubling your workload as a result of it. If you're going to give us specifications, give us the final versions, not something that's to be confirmed. Clearly, there are maybe situations where that's impossible. So we've got the big B word coming, and how that's going to impact some of this stuff may mean that things may need to be adjusted. Fine, put a rider proviso in there in terms of doing that. But make the specification clear. If you're going to stick a care plan in there, show us what the care plan's going to be. If there's going to be different ways of monitoring this, show us what it's going to be. If there's an expectation of a time frame for something to happen, give us that expectation. Don't just leave it open-ended so that actually it's hard to understand what is required for you to do, because that makes analysing the work that we need to do so much more of a challenge. Next up, stratify the spec for a category a year. So there are 5 specifications. The DES is 5 years long. Why not just give us one to deal with in year 1, and then stratify each one, so it's each year we're building up to the full 5 spec, because I think that would make many networks feel a lot more comfortable with the workload that is due to be achieved. Why? Well, don't forget, within this, in the current draft specification, there's over 30 different metrics that are going to be looked at. I think there's something like 50 different service specs in total. And actually trying to do that in the timeframes, trying to manage that in the timeframes, that's going to be a real challenge for many networks. And don't simply put, the metrics themselves, I would seriously say reduce them down. Ideally, per specification, no more than 2 metrics. Let the networks decide. Time and time again, we've heard this. It's the network decision. Let the networks decide what's best for their community, what's best for their population. That will work effectively, because we will see better care. And my final one in terms of time, solve the interoperability and IT issues. So many of you know me, I'm a bit of a tech guy and I love my tech, but hands down the biggest frustration many of us have within the tech and healthcare is the fact of the absolute lack of interoperability. And I will give you an example. So at the moment I'm working up one of the bids locally in terms of being a digital lead, at looking how we can develop and lead and deliver video consultations to our patients in line with the contract stuff and things. And actually we're coming up across so many challenges driven by the lack of interoperability. So for example, simply arranging for an EPS prescription from a hub to a spoke model, that is proving a significant challenge because the systems do not allow them. And there is no impetus from the developers to deliver this because they say there's not enough requests for it at this point in time. So we're going to have to work crazy workarounds that involve either delivering prescriptions by post, worst case scenario, or other kind of things just because the interoperability doesn't exist. And that's just within primary care. That's just within general practice. When we talk about working with our colleagues in community care, midwives working on different systems, district nurses working on different systems, these add to the workload. So actually fix interoperability and our IT. So, this is the last week that Windows 7 exists, and I hope every NHS system out there is now fully upgraded to Windows 10. But so many challenges still exist when it comes to single login, time wasted, all that kind of things. Focus on those, fix those, work on those before insisting that we then look at systems that make that even more complicated. And you will see within some of the later spec, the anticipatory and the personalizations, they are focused on the fact that you have decent tech and interoperability between systems to allow them to work effectively. And if you don't, it's not going to work. So fix those so that we can do it effectively. We're not wasting time. We're not wasting valuable public money on more workaround IT fixes. Yeah, you guys have probably figured out I'm quite passionate about this one because it's so frustrating and it ends up spending so much money. Let's talk about money. Let's talk about the funding itself. So I would, if I was trying to improve this, I would actually say we remove the requirement that the funding can only be used for additional roles. The reason why I say that, so I clearly understand the ethos about the fact that the additional roles will offer better workload capacity and stuff. And I do agree with that completely. But I also think that there are other things that networks have to deal with, and not having the resource to try and deal with those things is proving quite challenging. And having, again, to go off and do the standard NHS England thing of bidding for more money, really not nice. It makes it even more frustrating. So actually just let us use the roles, the funding, how we feel best for our local network. If you want to put some percentages in there, fine, do that. Just a small amount to allow us to have those opportunities. We've seen little pockets of this, so the OD funding that's been given to networks, in terms of being able to organise their training. That was great. That's nice to have those funding. But actually, and I'll give you an example. For our network, we realised that a lot of that funding we didn't need for that particular thing. We could have used that money better for other things to try and deliver services, to deliver effective engagement for our networks and that kind of stuff. So we've worked with the best that we could within the provisos. But actually, should that be the way, we could have used that money, for example, to start deliver services to work better and closer together. That would have been nicer than having to fulfill weird criteria just because that's what the criteria say. Next up, open the funding for the roles. If you're not going to allow us to use it for other things, if it's only for additional workforce, then let us use it for the workforce that we need, not the workforce that you're suggesting we have. So, for example, we know that there's different roles in there. So there's the community pharmacist, there's network pharmacists, there's first contact physios, physicians associates, there's paramedics and mental health workers in the first few years, as well as obviously the social link workers. And they're great. Some of those are really going to make a difference to primary care. But firstly, the Stratify, and I understand a lot of that is down to the workforce existing itself. So that's one of the reasons why paramedics are not from this April, but following April, because to make sure that we don't destabilise our ambulance colleagues and stuff. Definitely appropriate and definitely sensible. But then let's look at some of the other roles that might help us. Pharmacy technicians, occupational therapists, data analysts. Imagine what a network could do if they had a funded data analyst that did a lot of the challenging work that actually we shouldn't be doing because we're not the greatest people to do it. I love data and I'm awful at analysing it though, to be honest, because I'm just not that type of person. Whereas if I had someone that worked with me to analyse that data and look at the functions of how networks and practice can work more effectively, that intelligence would be so much more effective. So let us use the roles that we need. Fair enough, for some reason we're not allowed to spend this on GPs. We'll come to that in a second. But in terms of, nursing colleagues, healthcare workers, there are other workforces that would have a significant impact on general practice, and being able to spend that money on those would be so much more effective than just specified roles, because that's what people think is best. Next up, remove the 70-30 split. So I appreciate this is going to be slightly controversial, because I have no doubt there was a lot of negotiation that probably went in to get this to be 70-30. But simply put, if you want this to work effectively, remove the 70-30 split. Let us fully fund the roles from the funding that we've been given, particularly if the aim of these roles is to deliver the service specification, because then actually you take out that issue that you have from primary care having to fund work to do NHS England work when we're not even able to pay to do the core general practice work. That's the issue. So remove the 70-30 split, make 100% funded from NHS England, and let's do what we can. If that means that we can only have a small workforce, fine. It means we have a sustainable, workable workforce. Think about it. We'll see. In terms of other kind of funding aspects, so remove the necessity for a named clinical lead for each of the specifications. So this is, again, one of the issues that's come up time and time again in the forums, that each of the service specification requires that you have a named clinical lead for those specifications. However, there's no funding for it. There's no resources for it. There's nothing for it. And actually, that's a real pain to deal with. That's something that's really going to hurt people. And actually goes even deeper in terms of stuff. Because actually, if you want a person to take that responsible role, fair enough, it may be considered to only be one session a week or whatever per network. But that's still work that needs to be done. Across 5 specifications, that's 5 sessions a week. That's a half-time GP, effectively. And again, it's named clinical lead and all that kind of stuff. But fund it effectively. You know, we have funded time for clinical leads. I know some people have commented about the clinical directors doing this role in addition to what they're currently doing. That is the quickest way to make the networks fail, because then you will take these enthusiastic people who have taken on the roles and wanting to lead their local community to deliver better care, and you're going to lumber them with even more management and oversight and all the other kind of stuff on top of all the stuff they're already trying to do, which they're really struggling to do. So, yeah, please, no. We're going to come to another one around that later on in my exceptional section. And then last one, if for some reason that's not possible, if clearly they're not going to be funded from the clinical leads, at least let them work across networks. And the reason why I say this, in our local area, I'm proud of the fact that Nottingham has a collaborative network of networks, as I like to call it. And we've done really amazing stuff, and we work really well and effectively. And, one option that we considered was having, clinical leads work across networks, so you could actually create a role for an individual that focuses on improving the care home's patient care in terms of looking at anticipation care, because that's the thing that excites that one person. Because doing it for one session a week across an individual network may not actually be enough to get your teeth into and to fund effectively, because you might be able to fund it better through other routes and stuff. But if it's cross-network, that's a possibility. But the specifications actually states that shouldn't happen. It should be within the network. And I can kind of understand that. And some people say, well, just get one person to do all 5 of the clinical leads. Ooh, please, no. I'm not going to do that. So, yeah. Right, I'm just going to take a quick brief look at some of the comments and stuff. I said I'd try and do this throughout the document, and thank you everyone who's made loads of them. So hi Nick, hi Jonathan, good to see you on here. Trust is a two-way street, definitely agree with you there, Jonathan. The consultation, and I agree with Fazana not to walk away at this point. So where else are we? Love the thank you Daniel for your comment about loving a data analyst. Yeah, I think it would make a massive difference and stuff. And Rob Kettrell, hi, hope you're enjoying this, and yeah, hope you enjoy the rest of this. I'm going to crack on. So next section is talking about structured medication reviews and optimization. So this is one of the key areas that's meant to start from April and basically for the next year, and this is one of the ones that NHS England feel is completely achievable within year 1. I tried to look at how many patients I would have in my practice that would fulfill the criteria that NHS England have set out. I stopped after I got to the 2nd or 3rd criteria because working it out was quite challenging. So I would actually say NHS England, one thing, if you're going to try and help us do this, if you're going to make this achievable, give us the data analysis that allows us to extract this data quickly and effectively rather than us having to go off and create it ourselves. Because then you've got uniform data across various different practices that is equitable and effective. This one isn't actually in the notes. This is something I found out today whilst I was trying to do this. But it would make life a lot easier if we all had the same sort of principle that we're working off to find these kind of patients and stuff. So that's number 1. Number 2, the specifications talks about significantly longer than a GP appointment for these structured medication reviews, but doesn't actually quantify what that is. Is that 15 minutes? Is that 20 minutes? Is that the worst case scenario that many people are thinking 30 minutes? Because when you then look at that, for example, if we took the BBO document that estimates that approximately 20% of a practice workload will be within the criteria. And I'll be honest, from my initial looks, they're not that far off it. So I just looked at patients with more than 10 medications. That was 5% of our practice population already. So that's about 500 patients. I then looked at patients that weren't in that category, that were on high-dose opiates. That was another 400 odd. And then I looked at patients with more than one comorbid condition in terms of simply just looking at respiratory disease and hypertension. It's not even full cardiovascular, it's just hypertension, and that was another 200 odd patients that were not in the existing categories already. So that's quite a lot of patients, and that's just part of the requirements. That's not including the care home patients. So in my network area, we've got about 150 care home patients. Yes, there will be some harmonization between those. But you can quickly see how this becomes a large cohort of patients that fulfill the criteria for a structured medication review. I have no doubt that doing structured medication reviews can have impact on benefiting patients and particularly rationalizing their medications, and definitely looking at the opioid issue. Massive fan of looking at addressing that, because I do genuinely believe, like many people, that the opiates is a massive challenge that we're going to face in the next few years. But that's a huge amount of time. And then what really frustrated me about this particular specification is that it's then made worse by specifying it can only be a prescriber that does the review. Now, I understand to a degree why this may have been put in there, because there's the roles and responsibility to make sure the review is effective. However, I would argue that our pharmacy colleagues are very good at what they do. They're very good at knowing their medication. They don't necessarily have to be prescribers in order to review the medication. Yes, they do to issue it and to start new ones, fair enough. You can put systems in place within practices and networks to allow for that. However, to do the review, to advise them of the review, to be fair, it's only GPs that fulfill the criteria of being able to do that across all various areas of prescribing. A lot of chronic disease nurses and AMPs may be focused more on one particular disease condition like diabetes or COPD, maybe a couple, and I know some of them are really excellent and having multiple areas that they can look at. Our pharmacist colleagues may not be authorised to cover mental health issues, for example, because that's a more challenging one to be certified as a prescriber, and therefore as a result of that impacts the ability for their reviews to be fully effective on that basis. So remove the need for them to be prescribers. The other thing that will do is that will save the scramble that we're going to see if this goes ahead of people trying to get pharmacists who are prescribers, because there's not that many of them. And then the other thing that you'll see is loads of people signing up for the prescription prescribers courses, which is great, because I think it does say that you can be on the route to becoming a prescriber. All the courses are going to fill up, and then there's just not going to be any capacity, and you're going to have networks stunted because they can't use the workforce that is actually funded to do this work to do the work. And who's going to end up having to do it? It's going to be the GPs. Completely out of sync here. So definitely look at that. I think that's a quick and easy win to make this more sensible of a metric as a specification to look at. One of the comments I've heard in various of the forums, make the SMRs a paid for service, because actually it's going above and beyond the work of primary care. It is delivering a quality service, not necessarily essential service, and therefore as a result should this be paid for. And this may better help to fund some of the future work, particularly within the care homes and that kind of stuff, which will be an issue, and I'll come to the care homes in a short while in terms of why that's an issue. But this may help to fund the work better. If you don't want to do that, use it as the QOF payment for the next couple of years. Look at the QOF categories that actually this is the way that you're going to help support practice to make sure they affect quality, because it's quality if you do it, and also appropriately funded because it's part of QOF, and therefore that helps reduce the workload impact for primary care. Last little bit, so I mentioned this in my previous review of the specifications. I would love to see clarification of how patients may be contacted for their structured medication reviews, because unfortunately my reading of the document states that this has to be in writing, and therefore in writing typically tends to mean paper, letters, envelopes, cost, silly things, particularly when we're looking at digital innovation routes and stuff. So we are about to have the options of being able to notify patients on their phones through apps and systems that allow us to do that. Text messaging, allow it to be effective use of communications. So please clarify that wording to state that it's not just written communication in the sense of pen and paper, because I can unfortunately see that's what ends up happening, because that's how people always interpret these things. So, quick little look. Hi, Jonathan. Yep, joining us as a fellow Nottingham GP. And yeah, agree that the structured medication review workload will swamp us. It's interesting that the BBO actually looked at this, and when you look at their workload implications, they put this higher than the extended health and care homes specification, which actually that's the one that many people are concerned and worried about when it comes to the specifications. So let's talk about that one, shall we? Yeah. So the extended health and care homes is an interesting specification. It could have been effective, I think, and it definitely challenges a need that we have in terms of looking after vulnerable patients and stuff. I've had the great opportunity to speak to one of the people at the Age Concern group and their views on this matter, and you know how they were consulted, and they felt that this, you know, obviously the DES could have real good implications, but even they have said to actually, you know, consider stepping some of this back, that actually it's not become the thing that they envisaged, because it's become so metric laden, so bureaucratic in its process, that it's causing concern, and they don't want to see primary care overloaded with having to deal with all these workloads. So you know, we're not the only people who think this is ludicrous. I'm just going to say that. And I know that one of the comments I've had from my previous video is obviously the fact that I've called for someone to be fired. I'm going to reiterate it. Whoever put that line, about, you know, weekly reviews and you know, face-to-face and GP only, I maintain it. That person needs to be fired. It's a ludicrous statement. It should never have been put in there. And if you weren't trying to stir up general practice to be antagonistic, then you shouldn't have put that in, to be honest. Anyway, let's improve this, yeah? Let's change this. Let's make it better. So number one, do not put location and do not put age as denominators of healthcare. So the reason why I say this, the extended health and care homes looks at patients in care homes. And actually, that's not just the only category you need to look at. So one of the things that's really interesting by definition of this specification is that you could be a 85-year-old patient who lives in a care home, and as a result of this, you are potentially going to see somebody every single week to come and have a look at you, to offer you care, support, and look at your needs. You could be an 85-year-old person who lives independently, individually, and get none of that resource. That is a massive issue. That's massive inequality that this care home specification is going to drive. And that is wrong. I really feel that is wrong. So rather than looking at the location of the patient in a care home, rather than looking at the age of the patient, because age is relative, you can see 90-year-old people who are doing marathons, and you can see 50-year-old people who are just as complicated by their health issues as somebody else who's 80 plus. So let's look at something that's more valuable as a metric. Let's look at frailty. Let's look at those metrics that allow us to specify the patients that are vulnerable and need that kind of care. Yes, majority of them will probably be in care homes. Fine. But it will also help us address those patients that are not in the care homes, those patients with significant needs, those patients that need that help. Yes, okay, I know some people are going to say this harkens back to the unplanned admission DES, the 2% vulnerable patients and all that kind of stuff. Actually, the concept wasn't the problem with the unplanned admission DES. It was the execution of the unplanned admission DES that was the problem. So let's look at this effectively. Number two, remove the ridiculous premise that a GP or geriatric consultant, because there's loads of those hanging around as well, must lead the team. It's an unfunded part of the specifications. We've been told time and time again, there is no GP funding, there is definitely no geriatric consultant funding. So why are you specifying that this has to be led? Now, I understand the concept that some people are saying by releasing some of this workforce, by paying for all this other workforce, we will release GP time to do so. Have a look at the BBO's work document in terms of how much time you're going to need to do this. Across different areas and different patches, it's going to be a significant amount of time that is going to be taken, that is going to take those people away from patient care within their practice. And actually, that doesn't mean we're not still going to see these patients in between, because, to be honest, you don't get them well on time. That never happens. So it's just going to create more problems. In terms of, all right, and yeah, definitely remove the pedantic requirements for fortnightly or weekly visits. Networks should be able to decide what level of care their patients need. And I will harken back to using evidence. So the Nottingham Care Home LES was part of the Vanguard plans, and actually our requirements for that Vanguard LES, which we were paid significantly more money than is being offered in the care home element of this contract, only twice a year was the minimum requirement. And in actual fact, what happened then, our lead for that area was essentially they would visit some patients 4 or 5 times a year, and in the space of a couple of months, that person may be seen more intensely, and some patients were only seen twice a year because that's all they needed. So don't specify it has to be weekly, don't specify it has to be fortnightly, don't specify a time frame. Specify something that is effective for that patient and that area and that network, and let the network decide, because we're good at doing that. We really are. And lastly, for this particular part, definitely remove the requirement that it has to be face-to-face. So much of this care home work can be done, in my personal view, via virtual ward rounds, via telemedicine. I think this is an area where the digital revolution in healthcare can significantly help. Having something like a webcam in a nursing home is an easy and simple way of delivering better and confident patient care to our colleagues who work in the care homes and nursing homes and stuff, and also be able to save time because you're not having to physically go there sometimes to see some patients. Yes, there will definitely be some patients you still need to look at, listen to, see, that kind of stuff. You're going to need that input. But actually what more of these patients need is support to the care homes themselves to actually make them happy that what they're doing is the right thing. So sometimes just simply eyeball patients. And actually, we've got the staff there to help us to say, actually, I just need to have a look at that person's arm. Do you mind helping them lift it up so I can see it a bit more effectively? If people are interested, I'm a big fan of this particular camera that I'm using right now to record this video with. So that's the Logitech C920. I think if every nursing home in the country had one of these patched up to a Zoom system for practice to look at, you would have so much better care. And that, do you know how much that's going to cost you? Not a lot. That's £200 a year per care home. Well, not even that, to be honest, because the Zoom you could be used across to. So £50 for max for the webcam and £150 a year for the telemedicine system to do it. You would make life so much easier for everyone. Anyway, I'll crack on. The links for those are in the show notes if you want them. Definitely one thing that does need to have a look at, though, is the review of the nursing home requirements for these to be allocated to individual PCNs. I can understand that this may be a great idea and concept. However, it doesn't take into account the significant challenge this is going to take into account. And again, I'm going to use our local area as an example. So in Nottingham City area, there are 8 PCNs covering the footprint of the Nottingham City. I look after one of them. And in our network, we have 12 care homes and approximately 150 patients within that care home area. We are the second largest of the two networks to have that level of patients, care home patients. The largest, one of my colleagues' network, is smaller than us. I think about 55,000 patients, if I remember rightly. They have 24 care homes. They have over 300 patients that they would need to look after within their own network. Why? Because care homes are generally in areas where land is cheaper. That's generally the more deprived or sparser areas, and as a result of those are the areas that are going to struggle the most. And what, by nature of doing this spread, of defining by network, is going to happen is that you're going to further drive the inequality issues within network areas, because there's no difference in the amount of funding they get. It's based on capitation, and we've just established that a smaller network is going to get less money for a larger population. And as a result of that, it will fuel the inequalities for those patients. Compare that to another network area which only has one nursing home in it, similar sort of size, doesn't have to worry about all that different work because it's a much smaller nursing home and only a few patients. Here is where you drive inequality of care patients. Here's where you drive the problems. So actually that needs serious consideration as to how that works more effectively. And unless that comes with additional funding, like I mentioned earlier, in terms of potentially paying for structured medication reviews for networks and stuff, or paying for the care home LES. Because actually when you look at many practices, they will already have arrangements with care homes which allow them to be paid extra money to offer extra level of cares like regular ward rounds and stuff. That's going to destabilise some practices because they're going to lose that income and stuff, because that's going to be replaced by this. and therefore not actioned. And I know there is some anxieties about CCGs and stuff not continuing existing levels of care home packages if they're already commissioned. Now, clearly NHS England have thought this through and said that those funders should be re-enrolled back into primary care, and I completely agree with that statement. That's a great one to put in there. Thank you for that. And lastly, I mentioned that pay for reviews. So I'm just going to have a quick look at some of the comments. So I appreciate the strength of feeling, but there is evidence that outcomes for those in care homes are generally worse than those in the community, GBGS, hence the focus on this area. Yeah, you're probably right to a degree. I don't know the evidence on that particular part, so I'm not going to comment on it. But that doesn't mean that you forget those people in the community. And actually that's what this is driving. This is driving further inequality of care to patients who are based in one location versus patients that are based on another who may have the same or similar or even worse needs. So actually it's driving problems, and that doesn't seem to be considered. So next up, anticipatory care. I'm going to rock it on because I know we're short on time. I want to try and get this done in an hour. So anticipatory care. I'll be honest, I'm going to hold my hands up. I don't get anticipatory care in this context. Well, okay, so I do, but not to the depth of it, and I do have a bit of a knowledge gap in this area. But this is looking at basically trying to look at population-based healthcare. I have a slight problem with this because this is public health, and it's, again, general practice being asked to do more of the roles outside of itself. But I also accept that actually anticipating the needs of our patients and preventing their health issues can have better outcomes in the long run if it's done effectively and if it's done collaboratively, and that's where things like the ICSs and the ICPs and CCGs need to come together to work together. So how are we going to improve this? Number one, push back the timeframes. This is an easy one because this is one that's going to take relationships to be developed, and some networks just haven't had the time to develop those networks and those relationships in order to activate this. So therefore push this back by year 2, end of year 2, start of year 3, that kind of thing is a very simple one, and actually you'll probably have therefore better synergy with it working with some of the other ones. Next one, be specific about the monitoring at the outset. So I mentioned earlier about making sure that the contract is clear, the specifications are clear. This is one of the areas where almost every single metric is just not clarified at all. It's a to be confirmed, and I really, really, really hate that. So please don't do that. Stop. Anyway, moving forward, clarify the responsibility of who's paying for a lot of these tools. So this particular area talks about lots of tools like the Frailty Index and a couple of other tools that it mentions. But there's no clarity in terms of who's going to be paying for this, and my concern is that, as with many things that we've heard over the past 6 months, that the networks are going to solve every single problem. The networks are going to be able to stop people from attending A&E. The networks are going to be able to reduce waiting times for surgery. The networks are going to be able to basically do everything, provide smoking cessation services across the entire country, because public health no longer is able to fund them because local LEAs and stuff have stopped funding them themselves. Yeah, great. But in terms of who's going to actually be paying for these tools, and will the networks then be able to be told that they have to pay for access to these tools, that part's not clarified. And actually, if you're then adding additional costs that networks have to use from their £1.50 and that kind of stuff, then that's going to potentially destabilise some of the work they plan to do to benefit their local area, because they're now having to pay for tools that are being mandated by NHS England. So either make them free or clarify exactly who's paying for them, so we know that at the outset, at the very, very, very least. Clarify the evidence behind care plans and the need for monitoring, for example, the delirium assessment. So one of the lines was talking about a delirium assessment on every single patient. That was one of the metrics. Why? Can you show the evidence that is going to improve workload and that's going to improve patient care on the context of workload? Because let me remind you, the PCN DES is meant to stabilise general practice. None of this sounds like it's stuff that's going to actually stabilise general practice when you're talking about metrics for delirium assessments. We saw that with the dementia DES, we saw that with the unplanned admission DES. It didn't work to stabilise workload. It didn't work to stabilise that element of care. It improved potential quality, and I emphasise the word potential, but it didn't manage to do those. And that's what we're doing again. So there are massive alignments again. So my simple view is that any monitoring specification must lead to an impact on the reduction of clinician workload and or patient demand. If it doesn't do that, it shouldn't be a metric that we are asked to look at. Simple point. Personalised care. So this is the next category and the next specification. So this one is probably the most likely one to the unplanned admission DES. And you can see, I've talked about this a few times, it's because it was so painful to do. Not because it couldn't have been great, it was just monitored and managed and micromanaged to death that it just made it such a arduous process that it just didn't work effectively. And NHS England unfortunately seems to have developed its reliance on care plans for absolutely everything. None of them are identified in terms of what they specifically would be ideal to look at, and none of the tools seem to have been offered at this point. Fair enough, you've still got a few months to work out, but if you're going to, give us the codes, give us the tools, give us the structure, give us that information so we're not having to go off and create them individually, 7,000 different networks having to do all this different kind of work and stuff. No, sorry, 1,000 different networks. 1,000 different networks having to do off all this. Please just don't make us do that. Where are we? Next up was public health budgets. So I'll be honest, I don't still quite understand public health budgets because I don't have many patients in that situation, and this is one thing that the DES is actually asking us to look at, so to try and fix this, to make it available to more patients. So I don't know about it. Help me understand it. Can we have not some form of national training program that allows us to look at this? Can we not have a public campaign to educate patients what these are and how to access them and stuff, rather than making it individually regionalized and stuff? Why not provide us with those resources to make it effective? And so rather than passing that cost on to individual networks, do what you keep saying, economies of scale, create a national program that allows us to do that. For example, create a website that simply we can direct patients to say you may be eligible for public health budget. Just go to the website, fill it in if you want. We can print you off a piece of paper version, and then that tells you what you're eligible for, and therefore you can have that understanding and have a better idea of what's better for your care. Automate it. Talk about the things you keep asking primary care to do, and do them from a national perspective that therefore saves on economies of scale for networks, so then they're not having to do it themselves. I think that would work. Anyway, that's me personally. Remove the target for the number of social prescriber referrals. It just seems like an unnecessary thing. Social prescribers or social link workers and stuff have been seen as one of the methods to help improve significant amounts of workload. Why would we not want to use them? And putting a metric in that's the number of times they're referred to just seems pointless in my view. And clarify which PAM is being used, so patient activation measure. I had a little look into this because I'm again not au fait with a lot of this, but there's various different PAMs out there. There's a 100-point PAM, there's a 22-point PAM, there's a 13-point PAM. Which version are you going to be assessing us on? Because it's not clear in the document, it doesn't state that. And because there's a clear difference in workload in terms of which one we're having to look at. And even then, a 13-point activation mechanism that we were being asked to look at, to do that in a 10-minute consultation, you can understand that may not work so effectively. So we are going to have to use the additional roles to help us do that. Social workers, clearly, social link workers clearly are the benefit of doing this kind of thing. But that may still be a significant time difference depending on which role we're looking at and stuff. So please clarify that role. And definitely clarify the monitoring requirements. Again, I mentioned this one ultimately. And lastly, just remove the metrics for this particular one. So most of the metrics for this particular specification are exceptionally vague. They do not give a clear idea of what it is we're going to be looked at, how we're going to be assessed, and they keep mentioning words like quality. Quality is something that's very hard to assess when you don't know how it's being tested because it's not clear, and therefore that doesn't make confidence in the way that this is going to be managed. Unfortunately, NHS England has a really bad history of doing this kind of stuff, and I'm still slightly anxious about that. But then let's look at metrics that actually make a better way of doing this. Let's look at metrics, for example, like the number of amputations for diabetic patients, a reduction in those. Let's look at the metrics of reducing the stay of frail elderly patients because they're not bed blocking because there's no care homes for them to go to. Let's look at those metrics better when we talk about personalised care. I think that would be more effective. Lastly, I'm just going to finish off this quick topic and then we'll go take another break. So supporting early cancer diagnosis. So I actually think this is a great specification to stick in there. I think it needs a little bit of work, as with most of this, but I think that actually this is something that we should be doing more effectively. I also think it can be done quite easily as well. So the question, though, is about the time and the need for oversight, because, again, the specification seems to have taken what could be really positive and amazing stuff and just took tons and tons and tons of management bureaucratic speak on top of it. Anyway, so number one, Provide a data analyst. So I mentioned this earlier in terms of the roles and stuff, but actually I think if networks had a data analyst, this particular area, they could work so much more effectively. So let us either use the funding to do that, or provide a resource that that networks can access across from a national space in terms of looking at data analyst tools. Now I understand a lot of this will be available within local CCGs and ICSs. That's great if they're available in your area, but they may not be available everywhere, so having a look at that. Number 2, provide social media engagement and community education sessions to networks. What do I mean by this? Many people know I love my social media, and I actually think that social media and these kind of methods will enable networks to work more effectively with their populations. And actually mobilising the community to help us with this is probably the most effective way of doing it, because you get the community interest, you get them involved. And we've seen this with places like Healthier Fleetwood, how effective mobilising your community can be. And in order to do that, you need to be talking with the community and you need to be networking with the community. And social media has the power and the potential to do that. There's so many ways that can be done. And also community education has the power and method to do that. It just needs resourcing effectively for that to happen. Provide translation services support. I work in a significantly deprived area of the Nottingham City where majority population doesn't speak English. We have huge cohorts of non-English speaking patients, both in terms of language and in non-language, so in terms of deaf and that kind of populations. Apologies if I used the wrong non-PC term. And CQC hates us using Google Translate, even though it's a really effective tool, particularly for European languages, because it's backed up by EU data in terms of how they've done it. That's something the EU gave us, But in terms of using it, so let us have a resource that allows us to translate all of this media that we're going to have to create in terms of engaging populations and engaging communities and stuff, so we can translate it into the languages that matter to our communities themselves, because actually that means therefore we can engage with them better. And another thing that we can do is look at onboarding patients more effectively. We have this assumption in the NHS that everybody knows how to use the healthcare system and it's the patient's fault when they don't use it properly. Well, actually, isn't it the country's fault for not educating people? We have people that are new to the country that don't know how to use the NHS. We have people that have been born in this country that do not know how to use the NHS. Let's educate our populations more effectively about their health. Let's educate them about how we can effectively deliver care. And lastly, when it comes to this particular area, clarify the safety net metric. It doesn't quite make a lot of sense to me because I don't understand what terms you're talking about to safety net and how that's going to be measured. Are you going to be going through our notes and checking whether or not I've ticked a box that say I've safety netted? Are you going to be using a code? And it's a little bit nebulous, that particular one. So these are my suggestions. All right, I've got 10 minutes and I've still got a little bit to get through. So I'm just going to have a quick look at the comments. Personalised care for my PCN, that's 300 to 600 patients from Jonathan. Saturate additional workforce quickly. I completely agree with you there. Questions about the evidence. Sorry, not seen that. Personal health budgets can be transformative if you can get the system to release the money. Completely agree with you, Daniel, in that respect from what I've understood and seen them so far. And again, we find PAMs work best when patient completes it without the HCP present. So yeah, definitely looking at how we look at these kind of things a bit more effectively. Right, my last section is my more outward thinking. So I've talked about the existing DES and the specifications and stuff. This is stuff that I would add as my wish list. I'm going to rocket through these because I'm aware of time. Number 1. So the LMC conference had a landmark vote where they looked at removing home visiting from general practice. So if we're going to consider doing that, which can be swung either way, to be honest, I think there's pros and cons for how you look at this. Let's create a national acute visiting service using the roles that we have to affect this level of care. And I think this can work really, really well. So I'm going to harken back to one of my colleagues, Ben Gowland, going to give you a shout out there in terms of the General Practice podcast. And a recent episode just before Christmas, he had Dr. Paul Bennett on there talking about how he had actioned healthcare workers supporting a acute visiting service in a sense that they had developed within their practice using technology, so using video conferencing as a method to provide support to the patients as well as to the healthcare worker doing it. I think that's something that can be really valuable across our areas. Why not do this on a national basis? There are many patients, unfortunately, that still have this view that they should have visits for their element of care just based on how they feel rather based on need. I see this in my area, unfortunately, and I know that many people find this a challenging area to deal with, because actually home visits do have clearly their point in terms of delivering care, particularly in palliative situations, and we clearly have other patients who are chronically bedbound, and also sometimes we do have patients who are genuinely bedbound by the clinical issue that they're dealing with at that time. Having a nationalised acute visiting service may help to change the narrative about the types of roles that can be delivering this, because there's still the expectation that it always has to be the GP, and it doesn't. Actually, sometimes the GP is not the best person to be doing that visit, because actually that's not what's needed. So let's change the narrative. Let's create a national acute visiting service that can be effective across the entire country. Next up, we're talking about structured medication reviews earlier. Create a national formulary. So we have had significant challenges when it comes to supplies and medications over the past few months, intensified over the past few months. It's been a problem for many years, actually. But in terms of being able to have a more effective system, let's create a national formula. We have the book, we have the BNF that tells us what we should and should not be prescribing across our country. Let's rationalise that better. Let's use economies of scale to bulk buy medications to improve our supplies and to reduce variation and postcode lotteryism in terms of the types of medications that patients have access to across the area. This will improve supplies, hopefully, and mean that there's less issues when patients go and can't get them. This is probably going to be one of my most controversial ones. So charge for all prescriptions or charge for none. So I mention this because prescription poverty is a reality. I deal with this on a near monthly basis with patients that cannot afford their prescriptions and therefore do not look after themselves because they cannot do so. And this is despite talking about things like prescription exemption services. This is despite talking about lower income services and even prepayment certificates and stuff. But actually, if for some reason you wanted to continue charging patients for prescriptions, then just charge everybody. Why do we have a different tiered system? Just make it universal. £1 per item, for example. This worked with the plastic bag mechanism, because not only does it ensure that patients have the medications that they want, it will help to reduce wastage by requesting all medications on their list, because they have to now be mindful of the fact they're paying per item. But also it will then reduce the issue of attending the GP just to get a prescription because it might be free, which again is still an issue. There is also the lower items of low priority and stuff that are talked about, and there are definitely times when those items should be prescribed, and there are definitely times when those items should not be prescribed. However, if you didn't want to deal with this issue, if you didn't want to have this complexity, if you didn't want to have this challenge, then simply just do what other countries have done and just make all prescriptions free. Why charge some patients and not charge others? It defies the concept of equality of care, which NHS England and various cohorts are always banging on about, that we have to offer equality of care. It's not equitable when you charge one patient population, you don't charge another. Anyway. Redesign the prescription exemption process. This is a big thing that I find really, really frustrating. The prescription exemption service hasn't seen an overhaul for many, many years, and I find it truly, truly frustrating that you can have one chronic health condition and as a result of that have every prescription you ever may want for free, and then have another chronic health condition in another person that actually has more acute issues, for example, like COPD or asthma, that is potentially life-threatening in an acute situation on a rapid basis, but you are not eligible for free prescriptions, and as a result of that, you have to pay for your medication. As a result of that, you may not be able to afford them, and that fuels the damage that causes to yourself and also to the system, because inevitably what that may lead to is an admission to a hospital which will cost more than that person potentially would have paid for those prescriptions in several years' time frame. So change the prescription exemption service. For some reason this has not happened for many, many years. It is not conducive with current modern healthcare aspects in terms of the type of care we're offering, and simply put, it needs changing. This is a must-do, in my view, for NHS England to look at, or at least explain why this is not being looked at across our cost-effective elements of basis. Next, a national self-care and national program for self-care for both education and healthcare. And so what this is effectively, we know that many patients have a different expectation of what the healthcare system used to be and what it should be now. We need to start educating our colleagues. We need to start educating our patients. We need to start educating basically everybody. Healthcare is changing. That effectively how you access A&E needs to be different. We need to look at how the different types of roles that exist in primary care, because you ask many GPs, they don't know what half the new roles do. So how can we expect patients to know what half the new roles do? And therefore we reduce that complexity and that challenge that we have in practice. Oh, I'm not seeing that person, they're not a GP. That's not the point. You don't need to see a GP for everything. We need to echo that message across the entire country. And to be fair, the only way to do that is through a national program, both in terms of public health and both in terms of educating our children in our schools, because that's less effective, because everyone's been paying 10 times over for that kind of thing. National campaign to use the NHS app. So a couple of years ago, the NHS app was unveiled to the population that this was going to be the gateway in terms of you using your healthcare services. And then since then, it's kind of fizzled out. And I know this. So how do I know this? If you look on YouTube, which is a great marker of what people are searching for, okay? My video on how to use the NHS app to sign up, walks you through how to sign up, is currently about just over 1,000 views. That's not a lot, but it's a great thing for me, I'll be honest. But that is the highest ranking video when you search for the NHS app. That's saying something. If a homegrown video talking about how to use the NHS app is the highest ranking video, it's great on my standards, but in terms of that says something about how little effort is being actually put into advocating the NHS app nationally. Locally, I think there's lots of work being done, and I know particularly in Nottingham there's loads of real good effort trying to be put in, but actually we need the economies of scale. We need a national program to show patients that actually using the NHS app as your gateway into the healthcare services will have significant impact in terms of delivering better care to you, and it will get people using the same method, the same outcome, and hopefully as a result of that have better routes of care for people. Next up, and lastly, equal funding to clinical directors per network. So I am fortunate. I am working in a 66,000 patient network, which affords us three sessions of clinical network time, of which I use 2, and I have a clinical director who I could not do this job without at the moment, to be honest. And therefore, that means we've got a decent amount of funded time. It is unfortunate that networks of 30,000 only get 1 session, and actually the workload that they are having to do is exactly pretty much the same that I'm having to do, and yet they have much less funding. So let's just call a spade a spade. In reality, to do the kind of work that is required of clinical directors, there is a minimum requirement. It's not 1 session a week. It was never going to be 1 session a week. And actually, let's level these up. So my suggestion would be networks up to 75,000 patients get 3 network sessions, and those over get 4, because actually then how much more do you really need? And actually that may mean that networks are able to run a lot more effectively and stuff. So whistle stop talk, we're hit an hour. I'm really sorry it's taken so long. I've got some more comments on there. A&E should only be phone first, and then if the need's addressed, sort of. I kind of agree with you, Valishashar, but yeah, I think that could have issues in terms of outcomes and stuff. Where else are we? Nicholas Fazana, all very reasonable points re care homes, heterogeneity and patient desired outcomes. NHS app still doesn't work with our clinical system vision. Yeah, apologies on that, Nick. Again, interoperability. Hey, look what I talked about earlier. Fix it, people, please. If I could choose a metric for care homes, I would look at how many people are taken out for a fresh daily walk, and how many people are walking a few steps, reducing falls and low mood. This is not a GP role. Completely agree with you, Fazana. In terms of actually elderly outcome cares, one of the things that's most effective I've generally found is nutrition and mobility. You improve those. So Tai Chi classes whilst they learn how to cook with the family. Bingo, solved your problems for you. Give it a go. What do you think? Anyway, guys, I'm gonna. If you want to head off, feel free to do so. Thank you, everyone who stayed to this point. I really appreciate your time and your patience. If you stuck with me for this length of time. If you've got any comments or questions, feel free to stick it in the chat. I'm going to carry that on for a little bit longer. If you're watching this after the event or listening to this after the event, please leave a comment on the sections below, or send me a comment through whichever platform you prefer. So I'm on Twitter at @DrGandalf52. I'm on Twitter again as EGP Learning, Facebook on both of those, LinkedIn, Instagram, various different places as well. On the iTunes, definitely please leave a review if you found this episode helpful and effective. If you are leaving feedback, so we still have 2 more days to leave feedback, feel free to cite this video if there's particular parts you want to make reference to, because this is how I'm going to be submitting my feedback. I'm just going to be telling NHS England to have a look at my video. So Rob Kettle, consider this my feedback. You're going to get it shortly anyway in other ways. Again, I would love to thank everybody who's helped me to summarize all of this stuff. Definitely have a look at the GPSurvival link and stuff. And thank you to everybody on all the platforms that have continued to support and help me. Thank you to my wife for letting me do this as well. And I hope you all have a great evening. As I said, subscribe. And as always, EGP Learning is here to help save you and your patients time by taking hands in your primary care and learning. I'm going to go to the comments now. So, guys. Yeah, let's have a little look. Thank you, everyone. Thanks for the info as well. Time and space to think. Hope so, yeah. Apologies it's been so quick. Really tried to rattle through that for everybody. So Nick mentioned it. Of course, the most complex patients have the worst outcomes and end up in care homes. The question is whether the outcomes, meaningful outcomes for those patients, can be improved, and if so, how. Yeah, definitely agree with that. Jonathan, thank you. Yeah, national formulae. It'd make life so much easier. Cool. So it looks like everyone's heading off, so I'm going to sign off as well then, in fact. Okay, so thank you guys. Hope you've all had a great time. Thank you for your attention, and as always, if you've got any questions or comments, smash a like, leave a comment. Love it. Thank you, everybody. Yeah, I'll join you with a 14.5-hour day there, very Charlie and stuff. And yeah, thanks, Craig, for the comments. Everyone, catch you soon.